Hey guys, welcome back to the Foam Frat Podcast. We got a really cool episode today. I had on Dr. Natalie May to talk about RSV. And it's funny how this came about because I was wanting to bring someone on to talk about RSV. I was doing some research, went down a couple rabbit holes on what the evidence says for treatment. And so I just went to Med Twitter. And I don't know if you guys know you can do this, but if you just go like at Med Twitter, you can ask a question. You can say, who should I have on the episode for this? And they never let you down. Ashley Liebig tagged Dr. Natalie May from Sydney Hems. She's originally from the UK. She's board certified in emergency medicine. She pediatric emergency medicine, and she was a blast to have on. What'd you think of the podcast, Sam?
There's two things that I love the most. The first one was that she brought up the linear flow equation.
I know, that was really good.
That was really good. And the other thing too, I think that it was, who are we interviewing? Cliff Reed, right? So Cliff Reed and her, both kind of similar backgrounds, work for similar places and everything. And I keep picking up words from these people. So I picked up other stuff, but I picked up wangaroo, from Cliff Reed,
Yeah.
and that's been a staple. And I think I like their nomenclature for describing a really bad patient. And when instead of saying a patient is like in extremis, because that's what we would say if somebody's exhibiting like all the crazy signs of this disease process, and you're like, whoa, this patient's really sick with whatever they have. She says, or people in that area, I'm sure, say the patient was spectacular in their respiratory distress.
Yeah.
Whatever. And I was thinking about that. I'm like, that's such a good way of describing that, because you are almost taken back, and it's not like a spectacular, like, oh, spectacular, this patient, can barely breathe. It's
Good
like,
way. Yeah.
it's like trust me, when you see this patient, you're going to be impressed by how sick they are and how much we're going to have to treat them. If they are presenting spectacularly, it's a different like kind of swing on that word. So I thought that was great. The whole interview was good. A bunch of good points about RSV, bronchiolitis in particular. So I thought we would debrief afterwards and get some of the clinical information out there. And there's a couple cool points to talk about.
Awesome. Let's do it. So we're going to go to that interview now, and then we will meet you guys back on the tail end of this, the back end, to discuss some thoughts that we had. Dr. May, how are you doing?
I'm good, thank you. How are you?
Good. Thank you so much for agreeing to come on and talk with us. I was talking before we started recording, and I was telling Dr. May that I was introduced to her through Preston Fedora, who, when I first got into Hems, told me about your book, The 101 Lessons in Sydney Hems. And I'm going to put that up right here. This is an amazing book. If you're just getting into it, and you're just getting into even EMS in general, it was such a cool idea to keep track of like a diary of the things that you're going through and the different feelings that you have. And like you said, every job you would go on, you'd put a little reminder in there. And so I did the same thing when I started flying, and it's so cool to look back on that now. And I kind of stopped after like a year, just naturally I stopped doing it. But that was a really cool book. So I'm going to put that in the show notes, but that was like my introduction to you. And then I knew like you and Dr. Cliff Reed worked together, and you guys are both from the UK originally,
yes.
right?
Yeah. We've got a lot of Brits out at Sydney Hems and lots of Australians and other nationalities as well. But it's a really great group of very motivated people. And I think that's really what makes a difference. Increasingly, I think recruiting the right people to a service pays so much dividend in terms of the culture that you set and that pursuit of excellence. So I'm very fortunate to work there.
What was your journey like? So like did you always want to be a doctor, or did you get into it later on, or?
No, I wanted to be a vet, but then I was allergic to animals. So that didn't really work out very well. No, I think I decided on medicine in my teens, but I didn't want to do emergency straight off. I wanted to do forensic pathology, and then that became pediatrics. And then when I did emergency, I discovered that actually quite a lot of the things that I really enjoyed were the emergency side of pediatrics. And then I considered just emergency peds, and then I did peds and found out that actually a lot of the ped stuff I liked was really the very acute, and I wasn't so much into the more chronic disease management stuff, and there was adult-based stuff in emergency I liked. So then I ended up in emergency with ped subspecialty. I didn't want to do retrieval ever.
Really?
I had no interest, and I came out to do a Sydney HEMS job because of my education interest, because of my understanding of the way that they train, or we now train our new doctors, the way that we've standardized the way that we do things, our operating procedures, and the way that we train in teams. I think there's a lot of that's applicable to the emergency department, and I was really interested in working somewhere that had thought and invested in the education of their new team members. So I came out here for a year, and here I am 5 years later, now dual national, British and Australian, working as a specialist with Sydney HEMS and in the emergency department still. So I work in the emergency department in Sydney.
And you're an educator with Sydney HEMS as well, right? You do a lot of the education stuff.
Yeah, we have an education team. So Cliff and Claire Richmond is in charge of the education team, and then Rob Scott, who's an anaesthetist, and there's a load of really passionate people who were pretty innovative. Yeah. And we have some amazing paramedic educators on base. But we were chatting before just about the kind of culture of having people who are really interested in pushing the service forward, and always not accepting that there's not a better way that people can do things, but also mixed with a humility about the way that I do things might not be the best way to do things. And that's really refreshing. It's a great place to work.
Yeah, I've read a lot of your stuff on like giving feedback, and I've heard a lot of it through our mutual friend Ashley Liebig. And yeah, you guys are doing awesome stuff out there. We had Cliff on to talk about some stuff with just resuscitation logistics and scene management, and it's always great talking to you guys. I know that today the reason that you're here is because Ashley tagged you and said that you're her favorite person to talk about little people. And I had some questions about RSV, and with your specialty being in pediatrics, and you're still working in ED, is that specifically with pediatrics?
Yeah. No, I work in a joint ED. I am recognized in the UK as a pediatric EM subspecialist, and I'm not recognized out here in Australia as that particular denomination of emergency specialist, but that's mainly because I can't be bothered to do the paperwork and spend the money and do the exams again. But as I keep saying to people, the skills don't go away, the knowledge doesn't go away. So yeah, so I work in a mixed ED, and we see adults and peds.
And you have a kid too, right? So I mean,
I do, yeah. A child who had an
double
admission
qualified
with viral wheeze. Yeah, he had a viral wheeze type admission, so that was a fun time.
So we have seen like a pretty drastic increase in RSV cases, and I'm up here, and I'm borderline between Wisconsin and Minneapolis, and Minnesota, and we've seen an uptick not only in kids getting it, but adults getting it as well. And so I was like, all right, I want to tackle this because we do a lot of simulation just like you guys do. And during some of the debriefs, the topics have come up as to what is the evidence-based treatment for this? Like, are we doing nebulized adrenaline? Are we doing steroids? Is there any role for that? And so, as I started going through and looking at what the American Academy of Pediatrics was the resource I was looking at, I saw a lot of these things had really low-level evidence that they do anything. And some of the stuff that was mentioned in there was even down to like the diagnostic testing. Like they don't recommend routine chest x-rays and routine testing for RSV. So I wanted to start off with like the diagnosis of it. You have a kid that comes in, he's had a upper respiratory infection for a couple of days, less than 2 years old. There's like a certain criteria, and he presents with some retractions, some wheezing. What does your workup look like for that?
Well, it's a really common presentation, particularly over those winter months, and there's a huge crossover between the kids who are going to have kind of early asthma. And when I was training, we didn't even call it asthma in under twos. And I think now we've moved a little bit more towards bronchodilators in that age group. So that this is a really dynamic kind of field, which is, as you said, really evidence light. There's a lot of patients, and despite the fact there's a lot of patients, most of them turn out fine, and therefore they're going to get better anyway. And the answer is the question is really, how do we support them through that illness phase? So some of the units that I've worked in do viral swabbing, and we can talk about the usefulness of that in terms of identifying whether there is RSV there. Depending on the age of the child, there are some therapies we might consider trialing, like bronchodilators. But really, I guess the key thing is, in most children, they're going to be fine at the end of the day, and they just need some support to get through this. So actually, there's not a great deal that many of them need. It gets a bit complicated because when they're working hard with their breathing, particularly for smaller babies, it's really hard to feed. And that's the kind of that's the crux of it. The feeding and the hydration and the oxygenation are the crux of what we can use in terms of determining how bad this is going to be, but also in terms of how we're going to help this child to get better. So having a blocked snotty nose and having respiratory secretions and an increased work of breathing not only increases your losses, your hydration losses, your insensible losses, so you're going to need more hydration. It actually makes it a lot harder to feed, and particularly for breastfed and bottle fed small babies who need to have their noses cleared to be able to breathe properly and then to be able to have a good suck. They can get really dehydrated. So that's the main thing that we're thinking about. Is this, how sick is this child in their trajectory? How long have they been working this hard, and how dehydrated have they got themselves, and how much do we need to support them through that? And that, again, assessing dehydration is a huge minefield where there's not a great deal of evidence either in all the things we used to think about and determining exactly what percentage. In essence, it comes down to, can we estimate what's going in, how much feed they're taking, and can we estimate what's coming out, how much are they weeing? And, are they looking like they have circulatory compromise? Then we got the kind of the oxygenation side of things. So how effective is their breathing, and how hard are they having to work in order to maintain their oxygenation? And can we support them in some way? Do they need some extra oxygen in the air that they're breathing in order to make it less hard work for them to maintain oxygenation while they get better themselves? So really, our typical workup, we don't do a great deal. We're more about working out whether these kids have risk factors that are going to make them more at risk of having a serious presentation and things we're specifically concerned about. And then working out what they need in terms of support to get them through it.
It's interesting because we were debriefing an RSV case, and in the case, it had led to an intubation, right? And so we were like, if you look at the stats on this, like, not a lot of these kids get intubated. Like you said, they do very well. But there's maybe a little bit of a bias there because we're probably only getting called to the ones that are not doing so well, right? The ones that can't be discharged, the ones that need to go somewhere else. And so it can get in your head a little bit because you're like, oh, the majority of these kids don't need to be intubated, and I'm feeling like they need to be intubated now. And so, trying to paint that mental model, because you may not see a ton of these. I mean, we know, like, if you see the skin tugging below, like the sternum and stuff, and you see, their nose flaring, the typical like PAL stuff that you learn. Yeah. But like, does that mean that they need to be intubated, or are you looking for something else? Like, what makes you walk into a facility when you're doing a retrieval mission and go, that kid's going to need to be intubated right now?
I think you're right. It's really not an easy decision because they can work incredibly hard to maintain their oxygenation, but actually they can have recession or retractions, as you guys call them. We call them recessions in the UK, and they can be head bobbing and nasal flaring and all that kind of stuff. I'm more interested in the sort of downstream effects of that. So how is the child mentating? Are they awake? And they can be miserable and crying. That's still quite a good thing. If it's the kids who are lying there, who are really listless, who are putting absolutely everything they've got into maintaining their ventilation, they're the ones that really scare me. Because the other ones, you've got a little bit of time to try some suction, try to clear the nasal passages, make it a little bit easier, try a bit of humidified oxygen to see if you can help them to cough some stuff up, support them with a bit more volume, potentially some NG feeds can be helpful. You've got a little bit of time to do some stuff, but it's the ones who are completely collapsed out and just often they're looking pale, and the ones who are there, it's great if you can pick them because they're the ones who are about to be over the hill and in the downslope of they've got nothing left, and then they go very quickly to apnea and respiratory arrest, and they can get there. But that's the stuff I'm looking for. Everyone else they can be working spectacularly hard, I guess like I think about them in a similar kind of box to the patients with croup, in that they can be really spectacular when they turn up, but actually with the right bits of support, you can turn them around, and most of them don't need intubation. But when they turn up and they've clearly are at the edge of going down the precipice, it's a brave person who's going to say, this is definitely not going that way.
Yeah. Do you think there's a role for high flow nasal cannula or nasal CPAP in that range, in that area there? I know you said you guys don't do it a lot in retrieval.
We don't have the facility to do it. We don't generally transport sick children with Sydney HEMS. We do injured children, and we do take some sick kids that can't be managed by our specific neonatal and pediatric service, who I also work for occasionally. But they've only just brought online a new system that allows them to give humidified high flow. And it's the humidification that's been the issue in terms of transporting these patients. High flow nasal cannula, anyone can shove, you can do high flow oxygen. It's getting the humidification into the circuit that's been the issue. And of course, that's crucial for these kids. They need humidified oxygen rather than just the drying stuff that's only going to make things worse. So I think it's, if you're turning up and finding a super sick patient, the evidence isn't great for high flow. And there's a lot of meta-analyses and systematic reviews, and like so many things in medicine, we've failed to show that there's a really good survival benefit. We haven't shown mortality benefit, but I think it's a really difficult area to study, and it's definitely a practice that's used in emergency departments across Australia, much more than in the UK. And the tricky thing for me is that it came in very much as a practice. I don't know how much it's used in the UK, but between the time I left the UK and the time I started in emergency in Australia, which was like my year of retrieval and a little bit of extra time, it went from being this thing that was kind of theoretical to this thing that was everywhere.
Oh, wow.
And so I kind of walked into like, so we're doing this thing now. Okay, that's interesting. So I think it's definitely used, and anecdotally, it can make a difference. It can, if it's available to you, I would absolutely give it a try.
Try it before moving to like
absolutely.
the intubation route to see if
Absolutely. And if for no other reason than if you can improve your pre-oxygenation, then your intubation is going to be
that's a great point.
Go much better. So I would try what you've got available, even if the evidence isn't there. I think it's a relatively low risk thing to do compared to some of the other things we do that don't have a great evidence base. I think that the risks to the patient of trialing that are pretty low, as long as it's in the context of we're going to give it a try, and there's going to be somebody watching to make sure that this child isn't continuing to get worse. But unfortunately, the evidence isn't quite there yet. It may come. I
tried looking it up too. I was trying to like scan through it, and I saw a couple like small studies that it maybe decreased, hospitalization time, but nothing really, nothing solid. As I was looking at like the actual pathology that occurs in RSV, it sounds like you got like RSV is one of the like smallest viruses. It's super small, and it can make its way really far down, bypassing pretty much everything down to the bronchioles. And then when it gets down in those bronchioles, I had to look up the word syncytial because I was like, how do you say that? The S part?
Syncytial? Yeah.
Syncytial, yeah. I was like, and I know we're going to have a different way of saying it too, because of where we're at. But I looked that up, and like, here, look at this little picture I drew. Tell me what you think of this. All right. So I have like down here, the multinucleated syncytia, where you have like, there's no cell wall. It's just, they turned it into like this big viral factory. It almost looks like Shrek peeking over here. And then you have the healthy one up there at the top. And it sounds like it's just like the body's immune response to that is what creates all those thick secretions down in the bronchioles. And so what I thought was interesting though, is that mucus, because you're in such a small area, especially in a baby, that it can actually create like a one-way valve that only lets air in, but doesn't let air out. And you can start to build up auto PEEP. And it reminded me of like, somebody who has like really bad asthma. But it's different. It's not because of the actual airway. It's because of those secretions that are causing it. It's like a mucus plug. And so I was thinking about I wonder if nasal CPAP could help with that by kind of holding up that, that mucus plug or moving that out of the way. So unfortunately, I didn't find any really cool studies. If you guys out there listening have anything, or you've seen anything that I haven't found, then definitely send that over. But in that same vein, I was wondering, like, well, why does albuterol not work? Because, like, anytime we're going to a facility to pick up one of these kids, somebody's going to at least have tried albuterol at that point. And the more I looked into like the actual like anatomy of the bronchioles, there's not a lot of smooth muscle down there. So you're not going to get any bang. And it's different. It's mucus, right? It's not like the albuterol is going to get rid of the mucus. And so it's not like you can dilate out mucus. So that's why it doesn't really work. But is there any harm in trying it and seeing if it works?
I think as a one-off, but I suspect that the benefit that we're going to get is because actually you're aerosolizing something like
humidified
down into those bronchioles, and that's just going to help with the clearance of the mucus. And I suspect that's why we went down there when I was training. We were very much into hypertonic saline nebs for these babies.
Oh, yeah.
And that's really gone out of fashion. And I suspect, I think the thinking was the same. It's all about having something that's very salty that's going to draw the mucus out, but also it's providing some hydration. I don't know. But the evidence isn't there for that either. But again, anecdotally, we saw it seem to work. So I'm not advocating that as a treatment now. It's not one of the things that's on the table, but I think it's trialing one it might help, but I suspect the reason it's going to help is not the reason.
What about steroids?
Because of the medication. Again, there's been some studies around this, and there's no great evidence that steroids particularly help. And I guess I suppose I'm more wary. Like kids with asthma, fine, they can have steroids, but I'm a bit more wary of causing problems. I think steroids are a bit more problematic as a treatment. Not least because I've got a child, and when he had steroids, he predictably became even more wild than ever before. So if we can avoid that, that's ideal.
Do you typically see kids with RSV when they present to you, like in the ED, with a fever?
Not always. So I guess it's probably worth at this point talking about the kind of clinical course, because that's really relevant as well, because it also helps us when we do send them home from ED to be able to tell parents what to expect. So they often have they might have some upper respiratory symptoms first, and they often have a low grade fever, because kids will get a fever with everything, but it's not like a spectacular feature where they're febrile all the time. When they turn up and they're like, they've had a fever for 5 days, I'm thinking it's probably something else. It's not. If they're saying, it's been 40 every night for the last 5 nights, I'm thinking this doesn't really fit. So they tend to have lowish fevers occasionally, and then they tend to get sicker. And traditionally, the teaching has been that the peak is around about day 5 or day 6 of what is a 10 to 14 day illness. So if you're seeing them in day 1 or day 2 and they're already working quite hard, that's not necessarily a reason to bring them into hospital and for them to need to have something, but it's helpful to be able to say to the parents, you need to know that they're probably going to get worse over the next couple of days. And we expect that the peak of this is going to be at day 5 or day 6. Whereas if you're seeing them at day 5 and day 6, and they brought them because they just seem to continue to be unwell, as parents often do, my kid's been unwell for a few days, I thought they'd be better, but they're still unwell, and it's day 6 and they're still working a little bit, you can kind of go, well, actually, yeah, they probably do have something going on, but this is about as bad as I expect it's going to get. So it should start to get better from here. And it's helpful to know it's a relatively predictable clinical course as well, which is useful.
I was wondering. Sorry. Go ahead.
I was going to say, of course, there's that group of really high risk kids that are an exception to all of this. So
and those are like the preemies that were born early. Yeah.
The ex-prems, the congenital heart disease babies, if they've got any congenital lung disease, if they've got immune problems, if they are just small. So exactly as you said, the smaller the airway, the bigger the problem a little bit of mucus is, which is kind of why I file them in my croup box in my head, because it's the same thing. The smaller the airway, the bigger the problem, having something blocking it in that whole radius issue. The laminar flow theory, that if you're the laminar flow proportional to the radius to the power of 4. So
look at you just rattling that off.
Hey, look, You brought the cellular pathology. I could bring some laminar flow theory. So reducing the radius of the airway, even by a little bit, makes a huge difference. The amount of flow of air or gas that can get through there. So that's why small airways have big problems with little blockages. But yeah, so any of those kids, they're the ones that I'm really going to worry about, and the ones who just have sort of low birth weight. Any of those babies who traditionally fit in your box, where you're just going to go, oh, they're not your sort of completely happy, healthy baby. They've got something else going on. Then I'm going to think about them a little bit more carefully.
It was interesting. I was reading in the American Academy of Pediatrics, and then when I mentioned that I was going to be interviewing you, some of the providers I know said to ask you about the SpO2 goal, because they mention that you don't really need oxygen unless your SpO2 is less than 90%, like 90. And, obviously we're always like, God, that seems low, like, especially if there's an increased work of breathing. But some of the criteria I was looking at was like, if there is, no retractions and the SpO2 is at least 90, like some of these kids could even get discharged without having to be on home O2. How do you feel about that?
So this is a great point, because there's a fantastic little paper. I say fantastic. It's not the most robust paper, but it's really, really interesting. It's an open access. I think it's open access paper, published back in 2014, I think. And they used blinded adjusted SATS probes. So they randomized babies with bronchiolitis to have either a normal reading SATS probe or one that had the SATS adjusted up by like 4 or 5%. So if the SATS were 90, it would read 94. And they looked then at the outcomes and how they were kind of managed differently, and found no difference between the groups.
Oh, wow.
Which I think is fascinating. So
that is fascinating.
It took away our ability to act purely on that number. There was no difference between needs for high dependency or intensive care. There was no readmissions, like difference. Effectively, all of their outcomes were the same. So it's a fascinating little paper. It wasn't an ED based paper. It was a patient. So there was a slight difference in the group of patients from the ones that we would see. And I think that it was through a sort of pediatric assessment unit. So they'd already been screened into possibly a slightly higher risk group than we would see. So they were already kind of being admitted, but it still was fascinating to me that if you just simply by trying to take away that parameter and being a little bit more relaxed about what the exact number is, then there's potential that in our undifferentiated population,
it's interesting because
might not make a difference.
You guys do a lot of simulation at Sydney HEMS, and you guys, like when you're controlling I think you guys use iSimulate. I don't know what you guys use, but you can trigger people to do things based off of what you do at those numbers. You can raise this up a little bit or decrease this. And then all of a sudden you're like, all right, I want to get them to intubate. All right, well, let's just change this up. So there is definitely a response, trigger and response to how we see those in pulse ox. And I could think that even giving oxygen may even extend the hospital stay a little bit, because then you feel like you can't take them off oxygen unless they are maintaining above 90, 4 or whatever.
Yeah. I think there's a lot of logical fallacies in that in that thinking, and we do it all the time. And just to divert very slightly, one of my rants about when my child was admitted, he was a bit old for bronchiolitis, with his viral wheeze. I think he was 16, 17 months old, but we had to stay overnight because his SATs were low, and so he had to have oxygen overnight, and he had to have his salbutamol every 3 hours overnight. And then in the morning, they just took the oxygen off and discharged us. And I was like, we're going to go home and no one's going to check his SATs overnight. And you've done all of this treatment based on monitoring his SATs, which is now not going to be done for the next night. And magically, he's just going to be better. Doesn't make any sense to me. So, I mean, I was quite tired by that point, so I didn't put up a fight. But I think there's a lot of that in medicine where we just sort of blindly adhere to, oh, well, if this, then this, without questioning. And I think this why I like this paper is that they've been brave enough to go, you know what, maybe we're fooling ourselves because we're just acting on this one number, and actually it's not making any bearing. And I think to go back to the sim example, there's a difference if you're seeing the SATs falling in front of you. I think that probably should trigger you to do something, even if it's just to check that the SATs probe is still on. But I think with a good trace and a standard number, maybe we don't need to be quite so worried.
Yeah, no, that's fascinating. I'm glad you brought up that paper. I'll have to put that in the show notes.
I'll send you the link.
Well, are we forgetting anything else with RSV? Is there anything that you think EMS providers should know?
I guess in terms of it, the RSV itself, and so we do some swabbing in hospital, but that's usually just for cohorting patients. So we don't want to expose the sicker babies and the unvaccinated kids to that disease. But really, the principles of management are the same, whether you've got a respiratory panel, a viral disease or not. And it's all about looking at what the child in front of you needs. Do they need some support with their feeding? Do they need support with hydration? Do they need support with their ventilation because they're getting tired? And I think that's where the evidence lies. Those are the things that we know that we sometimes need to support. And again, how we do that is probably up for debate.
Is there anything that would make you think that this kid has like a mycoplasmic pneumonia? This isn't bronchiolitis. Like, is there anything that you would see that would make you think that it's something else besides bronchiolitis?
Yeah, so that's a really good question. And I think in older kids, my experience, and this is, again, we're getting into like the sort of gestalt, meaning the sum of the parts, and probably some of this is stuff that's actually really hard to put your finger on and put into words. But I've had more, I tend to order chest x-rays in kids who just have a little bit of work of breathing. I think they don't, the kids with RSV, bronchiolitis and viral, we tend to work really hard, whereas the kids with pneumonia, that it's not as spectacular, the amount of work of breathing usually, unless they've got a gigantic whiteout. But having a pneumonia in itself, they tend to just have a little bit of work of breathing, and they've just got slightly low SATs, and the fever will be more persistent and more of a feature. So if I'm seeing that constellation, and often a child who's just got that little bit of grunting at the end of their breath, do you know? So when they're auto peeping, so they kind of, I can do an impression of it.
Let's see it.
So they kind of go, and they just hold their breath that little bit of time just to maintain that, to keep their airways open, and then they just let the short expiratory phase, and you kind of hear that little kind of almost cough grunt. They're the kids that I'm looking at and thinking, there's some other pathology here. This is not usual. But then we can go into a debate about whether even x-raying those kids is a reasonable thing to do, because I might have already decided I'm going to give them antibiotics irrespective of what's on the chest x-ray. And if they're well enough to go home, do I need to expose them to radiation?
Are you, I remember what I was going to ask you. Are you into ultrasound? Are you an ultrasound guru?
I would love to be. I'm terrible at ultrasound, but I think ultrasounds are good. I'm really bad. I wish I was better. And it's one of the things I
feel like that's what everybody says who does ultrasound. We all feel like we're awful at it, but I was wondering if you could look at the lungs with ultrasound right there at the bedside and look for like air bronchograms or subpleural consolidations that make you think.
Exactly. That's a great idea, particularly for that particular patient group. The evidence probably isn't there in terms of a great RCT that shows that. If it is, by all means, send it to me. I'd love to see that, because that will definitely motivate me to get better at ultrasound. But if you're seeing focal pathology on your ultrasound and the rest of the lungs are clear, then that's not RSV bronchiolitis. You're expecting to see symmetrical, diffuse changes in bronchiolitis because it's a whole lung, both lungs, all lobes kind of affected type disease. So that's a really good point. Thank you for bringing that up, because I just don't think of ultrasound because I'm terrible at it.
Well, I thought of it because everybody's talking about COVID-19, right? And so one of the things that we were hearing is there's like irregular pleura, and they can get these subpleural consolidations. My buddy Chip Lang, he's a PA, he was talking about how viral processes are usually what cause subpleural consolidations. And so I started getting into that, and I was like, all right, I'm going to scan everybody to see, and there was on Twitter, there's people that were scanning their lungs, and they had a really irregular type pleura that was almost distinct to it, but probably more so just distinct to viral processes. And so I was thinking like, oh, it'd be interesting because who's to say the baby didn't aspirate some of mom's breast milk and is now has an aspiration pneumonia, and maybe we're thinking it's bronchitis. So maybe you could use that to differentiate. I don't know. There's probably, like you said, there's probably no papers on it or anything, but something to think about.
Yeah, absolutely. But I think even if I reckon I could probably identify whether there was symmetrical pathology versus, unifocal one area. That would be within my skill set, I think. So it's definitely a good idea to have a think about putting the probe on.
So that would make you think what? If you saw it to one side, that would make you think it's pneumonia?
Well, I would think, yeah, or at least not an RSV bronchiolitis. We don't usually, again, somebody will now send in a case report of like unilateral RSV bronchiolitis. And I'm sure that's happened because there's all kinds of weird stuff in medicine and patients don't read papers and they don't read textbooks. But generally, I'd be expecting to see symmetrical because, the RSV.
It's so contagious. It just replicates everywhere.
Absolutely. Yeah. It's the whole, both lungs, all lobes are affected. So if I'm seeing something focal, I'm thinking either there's a superimposed pneumonia, which is pretty unusual, actually. It does happen, but it's pretty unusual in these kids, or it's not. It was never that. It was something else all the way through.
Gotcha. Well, Dr. May, I can't thank you enough for coming on. This has been fun, and it's great to actually talk to you and to meet you. I've been a fan of yours for a while. If people are listening and they want to read more of your stuff, they can go to the St. Emlyn's blog. I'll put a link to that in the show note. You're on the editorial board for that, right?
Yes. Yeah.
And you do some blogs and stuff when you have time with the all the jobs and the kids and stuff.
Yes.
And then a podcast as well.
Yeah.
And then
we've got some stuff.
Yeah. Anything else? Is there any other areas that people? I know you have some videos on YouTube, so we'll give the whole Natalie May starter package on the show notes so they can follow you.
Yeah. I do some of the stuff for Sydney Hems, the Sydney Hems blog as well. So my colleague Claire Hayes Bradley is an amazing educator who puts together our intubation videos from the CMAC, and I convert them into blog posts with our learning points. So we share the airways in retrieval, which is an amazing resource, and I can fully endorse it in as much as all I do is put together her brain-powered amazing work. So that's worth looking at for anyone who intubates. You can learn so much vicariously from other people's intubation experiences. And we've started to do some podcasting over at Resuscitology as well, which is a course where we get to talk about the gritty nastiness of medicine from the pre-hospital world through to operating theatre, all the super sick patients, just with a team of us who are interested in doing that better, whatever that looks like.
Oh, that's awesome. Well, it's almost 10 a.m. over there, so I'm going to let you have the rest of your day, but thank you so much, and hopefully we can talk to you again.
Definitely. Thanks for having me.
All right, so what did you think, Sam?
So, bronchodilators. There's a strange thing that is a cover. What do they call? I mean, they use like salbutamol or whatever over there, but we call albuterol, albuterol over here. You have a kid with some respiratory distress, and what seems safer than giving some bronchodilators? Some pediatric dose albuterol, maybe some Atrovent. Seems really benign, but are you causing more complications than good, especially because, like you guys are bringing out, there's not a lot of muscles down there. What are you bronchodilating? And can your bronchodilator even get down that low? I was thinking about bronchiolitis. It's like little airways and little people, something like bronchitis, which, might work better in bigger airways, bigger people, but also more muscle up there. So I thought that was an interesting point about the bronchodilators. And that's what I found too in doing this research for a case previously for one of the case reviews in pediatric shortness of breath was the same thing. It was like, give it a once off maybe, but yeah, maybe the benefit comes from the extra fluid.
Yeah, that's interesting. She mentioned that the humidification probably is the thing that actually benefits the most. And I have to agree with that. It's funny because a lot of it too is not so much like a reactive type airway, but like the secretions are causing that narrowing of the airway because it's so small, and you get those mucus plugs where you have all that air in the back inside the alveoli, And then sometimes it builds like this one-way valve and it lets the air in, but it can't get out. And so giving albuterol is not going to dilate mucus, and like you mentioned, and we mentioned in the episode, there's not a lot of smooth muscle down there. So that's why you don't see that routinely used. However, I would imagine that most people, when they hear wheezing in a kid, their first mental model thing is to go to a trial of albuterol. And I think if you did that and you didn't know if it was like a new onset asthma or something, less than 2 years old would probably kind of, I don't know, be very young for that, but it could happen, right? And so if you gave that, you probably wouldn't be hurting anything. But if you didn't see results, I wouldn't keep stacking nebs on, excuse me, on top of each other.
Yeah, because at that point, I mean, even though you are adding some moisture to it, some humidity that could help with that mucus, if it's not really giving you much of a clinical effect, you could just be experiencing the bad effects. Like maybe you're just increasing the heart rate like crazy at this point, and that's hurting their perfusion because of the heart rate, or making the heart more hypoxic because it's working harder because of this beta stimulation now. So I thought that was a really good point. Speaking of those secretions, kind of on this topic of hydrating them and stuff, and a little bit of the nebulized saline stuff came up as well. And it made me think about, it was a while back. We actually did a podcast on the CF, the cystic fibrosis stuff. Yeah, we Tough Snot Kids one. And with them, if you ever give those kids any kind of saline, so if you give them regular saline, so if it's just 0.9%, or if it's hypertonic saline, those kids get super thick snot. And it's kind of a similar problem, but more widespread, because they have that whole thing where the snot gets super hard and it's held together by DNAs, all this kind of stuff. And so you have to hydrate it. And so they'll use hypertonic saline to get all of that fluid from the surrounding areas, pull it into the mucus, loosens it up, and they use other stuff. But they always do albuterol before they do any kind of hypertonic or regular saline, because that saline can actually cause bronchospasm and irritate the airway. So it's not just a benign treatment. The bronchodilators in a CF patient, they're not even really meant to dilate the bronchioles. They're mostly just meant as prophylaxis for not causing the patient to bronchospasm down. So it's something to think about. If you're going to go that route with a patient who you're like, oh man, we need some kind of humidification to this. If it's not one of those actual humidifiers for like your heated high flow nasal cannula, or just one of those regular ones that you'd mount on the wall for humidification through any airway device, if it's not one of those and you're actually using saline instead of like sterile water or something like that, the bronchoconstriction or I guess like reactive airway effects of it are something to think about.
Yeah, there's a tendency to be like, oh, we can do high flow nasal cannula. We'll just put them on a nasal cannula and crank it up pretty high, and maybe this will, stave off having to intubate. But if you're doing that and you're not humidifying it, you're just baking a crusty booger cake throughout their airway, and so definitely you don't want to do that.
Really small, deep down ones that are hard to retrieve, too.
Yeah.
And so that could cause a ton of problems if you're hardening those out. And the other thing that was brought up, and this is a word that I can never remember. I'm constantly asking Kristen what this is, because I understand the process, but for some reason, the phrase insensible loss exits my brain if I have not heard it within the past 24 hours. And like, what is that process called? It's some kind of loss where you can either sweat out the water, or you can breathe really hard and you're constantly breathing out this humidity, and you can lose tons of hydration that way. And so when these kids, this kind of comes back to the suction thing you guys were talking about, where it's like, you got to keep their airway, their nose particularly, as clear as it can get, because not only do you want them to be able to, how miserable are we when we can't breathe through our nose? They're obligate nose breathers. And then the adding insult to injury is those kids who they're now breathing through their mouth. You're giving them dry gas already, and now they're not retaining any of their own moisture. Plus, they're dehydrated because they can't feed because their noses are stuffed. So it's like not taking in fluid, breathing off a ton of fluid, and then just regular dehydrated from the dry gas we're giving them because we're not helping them hydrate anything. So those are some things that can stack up. You think about, is one of those things by itself like horrible? I don't know, maybe it could be enough to cause like a bad clinical effect, but then stack those three things up and it's like, are you going to could you make this quite a bit worse and get that stuff stuck down there? Probably.
Yeah. I thought it was great that you brought up the hypovolemia that can occur, because
Mhm.
you walk in, a kid struggling to breathe, you just start thinking airway, that you kind of get hung up in the airway portion of the assessment, where they do need volume, and that's probably going to be one of the main things they need at that point. So I was super happy that she brought that up. Um,
Oh,
oh, go
I was
ahead.
gonna give you a graphic for us to throw up, but I forgot about it. Maybe we can throw it in the blog. I have a graphic for that 4-2-1 rule for the pediatric fluid replacement. We can throw that into the blog. But essentially, there's a equation, and if you guys ever take like FPC or something like that, it's very common for this to be on there. By the way, is a 4-2-1 equation where up to a certain amount of kilos, they get 4 milliliters per kilo. Go up, it's 2. Go up, it's 1, and that's how you figure out your maintenance fluids for those kids after a fluid bowl. So maybe we can throw that in there, but knowing your appropriate fluid volumes for those kids would be important, because you wouldn't want to overload them either.
Yeah, and knowing that is the maintenance,
Yeah,
they're probably
maintenance.
going to need some resuscitation
Mhm.
first.
Yeah, after boluses. So if somebody's
Yeah.
already administered boluses and you're like, this kid's still mouth breathing, and I'm concerned about dryness, like what's our set rate for this? If they've already, if the blood pressure's stable, but they still need hydration, if you find yourself in that situation, that's where you'd probably use that maintenance fluid. Otherwise, yeah, you're going to give small boluses and figure that out. But I like how she brought up, like, how are you assessing that fluid status? What are you going to do? Ultrasound the IVC and look at, it's like,
Yeah.
probably not going to work too well in a kid who's probably got hypoxic vasoconstriction in their lungs, plus a hyperinflated chest and is whatever. So yeah, it's like you're probably relying on your regular signs, skin turgor and
Yeah.
mucous
Cap
membranes
refill.
and things like cap refill and things like that to monitor that hydration status. What did you think about the CPAP versus high flow cannula? A lot of people don't have high flow cannulas.
Yeah, and a lot of people don't have nasal CPAP either for
Yeah.
kids. They'll have like the CPAP mask or whatever for kids.
Hmm.
I tried to do some research on it. I didn't find anything crazy. I don't like the idea of covering up the mouth. I like the idea of being able to keep that inspiratory flow rate, because they probably are going to be sucking in quite a bit of air and then providing that pressure through the nasal cannula, the high flow cannula. But I guess if you had that instead of doing something like intubating the kid, that would probably be beneficial. We've also seen benefit putting the C-long helmet
Hmm.
on kids as well at my program. And so that's another option that we may start seeing increase. So I guess I don't really have any preference. I don't have a lot of experience with high flow nasal cannulas or nasal CPAP, because we don't have a humidification device. So we don't routinely do that. But the literature seems to support that it may be a good alternative to intubation.
Yeah, and for those of you who are thinking like, I'm kind of, I too am resource limited or equipment limited, and you're thinking, man, we don't even have. I've heard a ton of people say this. We don't even have CPAP for infants. Our children. We just have maybe you carry a flow safe, or what's the other one? I can't remember anyway. But if you have one of those adult devices, usually the attachment is the same for a pediatric. Maybe you don't have the pediatric masks. It's not ideal, but you can always use a bag valve mask as well in order to attach your CPAP to there, and that'll fit the patient's face, but it will be full face at that point. But some people have struggled with that, or they take the adult CPAP mask and they put it on upside down. I've seen that as well, where it makes the nose bridge is down here at the chin,
Hmm.
and then the whole face comes up over here over their eyes, which obviously you have to be very careful not to press on their eyes or anything like that.
You
So
look
it's
like a
very.
real clown walking into the hospital.
I know, yeah, and you would, but if you could
Remember,
get it.
guys, Sam gave you that tip.
Yeah, but so there's a couple different ways to try to get those masks to fit. But if you have somebody who's got these patients, they start off with pulmonary shunt, so it's a pulmonary side problem, and then it comes over and it can turn into a creation of dead space with hypoxic vasoconstriction. And so if you have to overcome that pulmonary shunt and high flow isn't doing it, you may need more pressure at that point, and then you're going to have to figure out how to secure something that generates pressure over their face if you're trying to stave off intubation at any cost.
Yeah, one of the things that really interested me is the diagnosis of RSV because it seems like it's mostly clinical presentation. There's
Mm,
not a lot of tests involved. They're not recommending doing viral testing, looking at viral load, PCRs, doing chest x-rays. And so I started digging in a little bit when I was thinking about using ultrasound. I started kind of just
mhm,
browsing, like, I don't know, the easy studies. I didn't dig too much. And I found one where they looked at diagnosing viral versus bacterial pneumonia. So this was pneumonia, not
mhm,
bronchiolitis. But I know you had some questions regarding the subpleural consolidations and like,
mhm,
why is that more of a viral thing?
mhm.
And the more I look at it, you can get subpleural consolidations in both bacterial and viral pneumonia, but they found that ultrasound is pretty good at detecting viral versus bacterial. And I wanted to show you this real quick because this is interesting. So this is the study.
Lung
Speaking of,
ultrasound differentiate between bacterial and viral pneumonia in children? Question
yeah,
mark.
yeah. So this was interesting. So what they did is they knew if the kid had bacterial pneumonia or viral pneumonia,
Mhm.
and then they looked at different findings. And so they looked for like diffuse B lines, irregular pleura, which is usually more associated with viral. I don't know if it has to do with how the lymphs go between the interlobular septi.
Oh, that's an
Um,
interesting idea, yeah.
but what they found was interesting. So if you look at this right here, so you can see that pleural line at the top where that X is, and then you see how big that subpleural consolidation is.
Yeah.
And so you see that the
It seems
little
like you
yellow.
can't tell where it kinda ends because you lose that plural line, and they call that like a fractal sign or a shred sign
Shred
sometimes,
sign,
right?
yeah.
Shred sign?
Yeah, so that shred sign plus a really long, so greater than 0.5 centimeter depth of a subpleural consolidation is associated with bacterial pneumonia. So,
Okay.
and the presence of those air bronchograms with that is a bacterial pneumonia compared to, look at this one. You see the small
And just
one
go
up
back
here.
one more time.
Yeah.
Go back to that last one. So, red arrows, we're looking at shred sign or fractal sign where you have that irregular plural line, and then you see kind of like a weird B line coming down off of it between those two red arrows. And then you're talking about the air bronchograms, those little white dots looking at the yellow arrows.
Yeah, and what air bronchograms are is the interface between air and fluid, air and secretion. So typically what happens is you have, fluid that's inside an alveoli, and then you still have some air in the bronchioles, and that interface gives you this air bronchogram look. And you can have static versus dynamic air bronchograms, but those air bronchograms were associated more so with a bacterial pneumonia. And so then I'm going to show you this one, and you can see there's a irregular pleura. So you can see that in the in actually in both of them, but really in C, you can see that
Yeah.
pleura is
And in
irregular.
A, you kinda lose it a little bit.
Yeah. But look at the subpleural consolidation. Or I guess the correct term is subpleural lesion.
Okay.
Now that they don't want you to say consolidation unless you actually
Sure.
know, but the lesion there, see how it's not that deep?
Which
And
image one?
so what's that on A?
Which A, okay, yeah, I see how it's not that deep. I don't know what the measurement is. Do you know how deep that whole image is? I don't know if it says on there. It
Well,
probably
it
doesn't
says
say.
down there that it's 0 by 0.26 centimeters. So
Okay,
that's
alright,
the
sure.
depth is the
Okay,
zero point 0.2.
okay,
So it's less than 0.5 centimeters.
okay.
And so those are more associated with a viral pneumonia. And so are the diffuse B lines. You want to see like 3 extending down for every intercostal space, extending down to like the 10 to 12 centimeter mark. But I thought that was interesting because I was thinking air bronchograms because in a patient who has bronchiolitis, you have that mucus plug and then you
Mhm,
have the air on the other side. Like it's
mhm,
kind of swapped as it would be in a pneumonia. So I would think you would still get those. And I found a couple papers that showed that when they did lung ultrasound to try to detect bronchiolitis in kids, the most common finding was subpleural consolidations and air bronchogram. So you can still get that. What I like about this is a picture mom is holding the baby like on her chest. It's so easy to go up and scan their back and get down in the posterior regions and
mhm.
down in the inferior regions. as opposed to trying to get them to lay still for an x-ray, chest x-ray, So I think that there could be some utility to, while mom's holding the baby, just going up and scanning their back.
How I picture these subpleural consolidations or lesions or whatever, and I finally figured out what that graph was looking at. That little X's, silly, those little X's and Y's were measuring the actual lesion, right? That's actually what that
On
was.
this
And I
one?
asked that. Oh no, the second one, when you told me it was 0.26 or whatever, I didn't realize that 0.26 is the X, and then the
Yeah.
plus is going from the other side. So okay, that makes sense now. You were saying less than 0.5. I understand what you're saying now. And now I friggin' lost my thought. What was I saying? We were talking about the lesions, right? Yeah. So I've always thought of those lesions. Are they hard to find? Because it seems like, let's say you're scanning for a pneumothorax or something, and you're looking for this massive loss of lung sliding. And so let's say you do 2 zones in the front, upper and lower, and then up in the armpit and a little bit further down. Maybe you, like you said, you're doing it on the back. I guess in my mind, maybe there's more of them than I'm thinking, and maybe they're all over the place or something. But I was always thinking it's this needle in the haystack, where it's this little round thing, that you're looking for in between these intercostal spaces. Are they supposedly hard to find? You have to scan the entire lung zone to find one of these, or are they just popping up all over the place?
Yeah, there's a way they recommend you scan. Most of these are going to appear posterior, though, because the most common cause of a consolidation, which I should really call it a lesion again, is atelectasis, or it can actually be a infiltration, right? A consolidation of whether that be some interstitial disease that's made its way into the alveoli. But if you don't know if it's atelectasis or consolidation, you can look for things like those air bronchograms that would make you think that there's actually fluid in there, as opposed to just being alveoli that have collapsed and atelectasis. So there's something called the Blue protocol, which recommends like different scanning lines that you want to go down. And so you don't want to do it like you're doing a pneumothorax scan, lung sliding, where you're at the most anterior portion. You want to get in those back lobes, because that's, kids laying on their back the majority of the time. That's where those things are going to start to develop. And that's why I think it's easy when mom's holding baby to do the back, do it right there.
That makes a lot of sense. I think the other thing, like clinically correlated thing I was gonna bring up, was that incidence of apnea, and I think you took a screenshot of the paper that I
Yeah, you
sent you.
just want to read that to us real quick, Sam?
Well, I'll just the first line here, apnea. And so anytime you say apnea in a kid, like, that is scary, and they bring out
Yeah.
like that's one of the most frightening things. And it says like just that second line there, up to 20% of infants hospitalized with RSV infection, and like talking about bronchiolitis, have been admitted with apnea. And in the ER evaluation, unspecified bronchiolitis, 3% had a diagnosis of apnea. So that's like a really scary thing. I was reading more about that, and it was more common if you were, I think, and maybe in that post it said something about below less than 32 weeks, if they're carried less than 32 weeks or around that area. And then the other one was just less than 3 months of age in general. And obviously you can get bronchiolitis from different viruses as well, like rhinovirus or influenza, but it was the apneic episodes were the most common in RSV virus. And the younger they were, the more likely they were to have these apneic episodes for a various amounts of time. Could be brief, could be extended, but that's just something that's one little information. That's a scary piece of information that might make you think, like, I'm going in on this call and they're transporting this kid and he's kind of sick, or he or she is kind of sick. Maybe I won't have the BVM in the bag. Maybe I'll take it out of the bag and I'll put it on the cot or whatever, just in case this were to happen. So it's just something that there may be an episode of apnea where they didn't progress, and some of that literature says that they can present with an episode of apnea and then develop worsening respiratory signs later on. So that's a really weird thing, and it's not well understood at all. But it's one of those things where it's like, oh, that would be good to know, that this kid can stop breathing randomly, especially if it's RSV. So just something to kind of throw in your clinical tool bag as a, not an afterthought, but as something that could seriously happen.
Yeah, no, I think that's a great idea with just thinking about the stuff that you bring in on a call. I remember, when I first got started in EMS, I would always ask, what do you guys bring? Do you bring the monitor, the bag? You remember you'd bring the blue bag and you would bring the monitor, but do we need to bring the airway bag in on every single
Mhm.
call? So just having that little bit of a tidbit of information probably helps a lot.
Yeah.
All right, man. We'll close it out. Again, this episode is brought to you by the Foam Frat EMS and Nursing Library. If you guys are interested in checking that out, go to foamfrat.com/courses and check out our classes that we have. We do live classes Monday through Friday, 9 o'clock, 1 o'clock, and 6 o'clock Central. Thursday, we have a 5 o'clock evening session. And then on Friday, we just do the 2 in the morning at 9 and then the afternoon at 1. But in addition to that, we got over 150 hours of self-paced content, 24 hours of critical care. So if you guys are interested, definitely hit us up if you have any questions.